Hello everyone, welcome to Diagnose It. Today we'll discuss this new case, and this is a 45-year-old man who presented with epigastric pain, fatigue, generalized edema, and this kind of endoscopy picture showing the gastric mucosa. Well, by this appearance, there are some differential diagnoses that should come to your mind, and these are one is this Zollinger-Ellison syndrome. Other is some kind of polyp of GI mucosa, adenocarcinoma. Next is this Menetrier's disease. And there is hypertrophic gastropathy, and hypertrophic gastropathy can be hypertrophic lymphocytic gastritis or hypertrophic hypersecretory gastropathy. And there are some infective causes like association with H. pylori gastritis and like associated with histoplasmosis, tuberculosis, some infiltrative disorders like sarcoidosis. Well, these are the main differential diagnosis by this appearance of gastric mucosa. Firstly, let's discuss some points about all of these, but in the end, we'll focus on our main diagnosis that I'll tell you. Firstly, what happens in this Zollinger-Ellison syndrome? There is a gastrin secreting tumor, and in turns that gastrin stimulates the stomach to produce more amount of gastric acid, and that gastric acid leads to development of various ulcers, and these ulcers are more over atypical locations and mostly resistant to the PPI, the proton pump inhibitors, and other antibiotics that we give. Next is this polyp, and the polyp, the thing is this polyp is usually localized swelling. This diffuse kind of polyps are rare. Next is this adenocarcinoma. Well, in earlier stage, adenocarcinoma is also localized, but in later stage, yeah, it can be diffuse also. Next one is this hypertrophic lymphocytic gastropathy and hypertrophic hypersecretory gastritis, and this Menetrier's disease. Well, these three are kind of mimickers of each other, and these basically are differentiated on the basis of biopsy. Like in this hypertrophic lymphocytic gastropathy, in the mucosa we can see lymphocytosis, that there are more number of lymphocytes in the mucosa. In this hypertrophic hypersecretory gastritis, there is hypertrophy of all type of cell in the stomach that leads to production of more amount of acid, more amount of that pepsin hormone that is secreted, and more amount of mucus also. But in the Menetrier's disease, what happens is there is more amount of mucus production, but there is decreased amount of gastric acid production and other hormonal production, and the hyperplasia is mostly of the foveolar epithelium. So these are basically differentiated on the basis of biopsy, and the biopsy that you can see, this biopsy was from this patient, and after this biopsy it was diagnosed as this Menetrier's disease. Now let's start our discussion, and let's discuss about this Menetrier's disease in more detail. We'll follow a regular way of discussion of any disease. Like firstly we'll discuss about what is this Menetrier's disease, then we'll discuss about why it occurs, the main pathogenesis behind this disease, then we'll discuss about how the patient presents, the main symptoms of this disease. Then we'll come to the diagnosis part, and in the end about the treatment part. Well, firstly starting with our what? Well, it is basically a rare disorder that is associated with the giant mucosal hypertrophy, decreased acid production, and also protein loss. This protein loss leads to development of hypoalbuminemia. Well, due to this hypoproteinemia and this hypoalbuminemia, it is also called as hypoproteinemic hypertrophic gastropathy, and due to this giant mucosal hypertrophy, this is also called as giant hypertrophic gastritis. Well, it most commonly occurs in 30 to 60 year of age, and more prevalent in male population as compared to females, and this is an acquired disorder. In adults it is mostly a progressive disorder, but in children this is associated with CMV and H. pylori infection, and most of the time this is self-limiting disease, and the child get better within some weeks. Now let's come to the why of this disease, and this is very interesting. Well, what happens is there is this increased expression of TGF alpha, this transforming growth factor alpha, and as you know that this TGF alpha acts on this epidermal growth factor receptor. When this acts on this epidermal growth factor receptor, this basically stimulates the growth of gastric mucosa. Next thing is what this TGF alpha do. Well, as you know, there are three cells. One is this mucin producing cells, this goblet cells. One is this chief cells, and one is this parietal cells. These three cells are basically derived from same progenitor cells. And what this transforming growth factor do, this basically increase the production of mucin producing cells from this same progenitor cell, but decrease the production of this chief cells and parietal cells. One more thing, due to the chief cell and parietal cell number decreases, there should be this increased amount of gastrin secretion, because gastrin is basically trophic for these two. But what happens in this disease, there is this gastrin level. These gastrin levels are normal. So that is why the number of these chief cells and parietal cell is decreased, and this mucin production is increased. So this mucin is increased, this decreased HCl production, and this decreased pepsin production. So now what happens is, due to this gastric mucosal hypertrophy, this kind of appearance, this cerebriform appearance of gastric mucosa occurs. Due to this increased mucin production, there are various theories. Like due to this increased mucin production, one is the excess mucus leads to malabsorption due to the decreased transit time of the food in the stomach, and also this leads to decrease in the iron absorption. And when the iron absorption is decreased, one is it leads to anemia, which is very commonly seen in this disease. And this decreased iron absorption also leads to disturbed mucosal functioning of the whole GIT. And the whole GIT now cannot absorb the amount of protein that it should normally absorb. So that is why hyperproteinemia, decrease in the albumin in the body. So that leads to hypoalbuminemia. And this decreased HCl and this pepsin production, this also leads to malabsorption. So this is the main pathogenesis behind this disease. Let me explain it again. Firstly, what happens is there is this increase in amount of transforming growth factor alpha that acts on this epidermal growth factor receptor, and this leads to gastric mucosal hypertrophy. And this gastric mucosal hypertrophy leads to the cerebriform appearance of the stomach mucosa. And one more specific thing about this disease is this disease mostly affect the proximal part of the stomach, like body and this fundus of the stomach are involved, but antrum of the stomach is spared in this disease. Next thing is due to the increase in mucin production. As I explained here, there are the same progenitor cells that leads to production of mucin producing cells, chief cells and parietal cells. And this transforming growth factor basically shifts more number of this progenitor cell for the production of mucin producing cells. That leads to increase in this mucin production. And so that is why less number of cells are there for the production of chief cell and parietal cells. That leads to this decrease in HCl and pepsin production. And due to the increase in mucin production, there is decreased absorption of iron that leads to anemia. And also due to increase in this mucin production, there is decreased transit time of the food in the stomach and whole GIT that leads to malabsorption. And also due to decrease in iron absorption, there is malfunctioning of GI mucosa that basically leads to decrease in the absorption of the food that also leads to hyperproteinemia. And there is this decreased HCl and pepsin production that also leads to malabsorption of the food. So this is the main pathogenesis behind this disease. Due to this increased level of TGF alpha, one more thing can also occur, as this is a kind of a carcinogenic molecule that leads to development of cancers due to the overexpression of this K67 antigen over the cells. So that is why this disease is also a pre-malignant disease and also leads to development of adenocarcinoma of the GIT and mostly of the proximal part of stomach. Now let's come to the presentation of the patient. First is the symptoms like epigastric pain, fatigue, generalized edema. The other features are weight loss, vomiting, GI bleeding, gastric erosions and ulcers, this ascites, pleural or pericardial effusion. And you can now clearly understand why these symptoms are occurring. Firstly, this epigastric pain. Why this epigastric pain is occurring? Due to this gastric mucosal hypertrophy. Why the fatigue is occurring? Due to decreased absorption of iron. When the patient is developing anemia, that leads to this fatigue. And also due to the malabsorption, the patient can also develop fatigue. Why the edema is occurring? Due to decrease in the protein absorption, due to hypoalbuminemia, the edema occurs. And why this ascites and pleural effusion is occurring? This is also due to this hyperproteinemia. Why this GI bleeding and ulcers are occurring? Due to the decreased absorption of iron, as we stated, the mucosal integrity get disturbed. That leads to this ulcer production and in turn lead to this GI bleeding. Why the weight loss and vomiting is occurring in the patient? Well, the weight loss is occurring due to the malabsorption, and why the vomiting is occurring due to this excessive mucin production, due to this excessive hypertrophy of the GI mucosa. This basically hinders the input of the food in the stomach that leads to the development of vomiting in the patient. So these are the basic presentation of the patient. Now let's come to the next part, the diagnosis, how we diagnose this case. Well, for the diagnosis after these presenting symptoms, the investigations that we do are basically this barium swallow and endoscopy. And with endoscopy, we also go for this full thickness mucosal biopsy. We must go for this full thickness mucosal biopsy because as we discussed earlier, there are a lot of mimickers of this disease. So to differentiate this Menetrier's disease from those mimickers, we should go for this full thickness biopsy. Well, firstly in this barium swallow, as you can see here, this is the stomach. And in the stomach, you can clearly see there is this hypertrophy of the gastric mucosa due to the filling defects. As you can see, there are a lot of filling defects here due to the irregularity in the stomach wall. And you can see one more thing, that is the proximal part of the stomach is involved, and this distal stomach, this part is spared. This is the characteristic of this disease, like this proximal part is involved. Next is in the full thickness mucosal biopsy. As you can see, this part here, these are the mucin producing cells, this foveolar hyperplasia. And what this foveolar hyperplasia, this basically means the hyperplasia of the mucin producing cells. The next thing that you can see is this glandular cystic dilatations. Plus there are a lot of inflammatory cells, as you can see here. And in the inflammatory cells, there are a lot of eosinophils basically. Characteristically, eosinophils are deposited. Well, in the biopsy, along with this foveolar hyperplasia, there is one more thing that is seen. There is this thing called parallelism of the glands. Like as you can see, these glands are arranged more parallelly to each other. This is quite characteristic for this disease. And this also happens due to this foveolar hyperplasia. Well, we should not stop here. We should also go for this CMV and this H. pylori screening, because these are also associated with this disease. And when these are associated, we can think of the disease can be self-limiting also. But if these are not associated, the disease is more of a kind of progressive disease. And most of the time in adults, this is a progressive disease. But in children, this association with CMV and H. pylori, this can be a self-limiting disease also. Now, in the end, let's come to the treatment part of this disease. Well, firstly, in the supportive treatment, we should give the patient a high protein diet along with the replacement of micronutrients, because this disease is associated with malnutrition, and these two should be replenished in the patient. And if the disease is associated with this CMV or this H. pylori, then firstly this should be eliminated. Like this CMV is, like for the CMV we use ganciclovir, and for this H. pylori infection we go for this SCAP regime. There are some drugs that are tried in this disease like octreotide. Well, this octreotide is basically somatostatin analog, and it basically acts by modulating the TGF alpha EGFR pathway that we have discussed. The current drug of choice for this disease is this cetuximab. And this cetuximab is this IgG1 monoclonal antibody against this extracellular domain of this epidermal growth factor receptor, where this TGF alpha bind. And this basically inhibits the binding of TGF alpha that leads to a very good outcome in the patients. Well, this is a medical management, but in the earlier time when this drug was not available, or in the severe condition, when the patient is in quite severe condition, the drug is not effective, then there is this surgical treatment for this disease. We can go for partial or total gastrectomy. Basically, total gastrectomy is preferred over the partial gastrectomy because of some kind of better surgical outcome. So this is all about this Menetrier's disease, and if you have any questions regarding this disease, then you can post it in the comment section below, or you can DM me on my Instagram handle at @diagnoseIt, and I'll try to answer them. Now, in the end, I would like to discuss a saying by Sir William Harvey, who was a great physician and a scientist, and correctly described about the human circulation for the first time. And he said that nature is nowhere accustomed more openly to display her secret mysteries than in cases where she shows tracing of her work apart from the beaten path. Nor is there any better way to advance the proper practice of medicine than to give her mind to the discovery of the usual laws of nature by carefully investigating the cases of rare forms of the diseases. So what this statement means, that if you want to know the undiscovered secrets of the nature, then the study about the rare diseases is the best way to discover those. So that is why we also discover some rare diseases along with the common ones. So don't forget to like our videos and subscribe to my channel. Thank you.